Learn with Livanta, Medicare, the BFCC-QIO, and you. Livanta's podcast where we bring you up-to-date information about QIO services and the overall Medicare landscape. Livanta holds a contract with the Centers for Medicare and Medicaid Services as a BFCC-QIO, or Beneficiary and Family-Centered Care Quality Improvement Organization. BFCC-QIOs are contractors hired by Medicare to make sure that Medicare beneficiaries receive the care they deserve. All Medicare beneficiaries have a right to high-quality health care, and BFCC-QIOs like Livanta protect that right. There are three primary services that we at Livanta provide at no cost to Medicare beneficiaries. Medical record review, which is when a beneficiary wants to appeal their discharge from a hospital or the termination of Medicare-covered services in nursing homes or other settings. Medical record review when a Medicare beneficiary believes they received poor quality or substandard health care, and immediate advocacy, which is a service Livanta provides to help beneficiaries and their families when they are having problems with their care or Medicare-covered services. In this month's episode, we have the opportunity to have an extended conversation with Dr. Matthew Stoffren, the medical director of the Livanta BFCC-QIO, about winter wellness for older adults and discharge planning. Dr. Stoffren is a graduate of the Johns Hopkins University School of Medicine and is board certified in emergency medicine and internal medicine. In addition to maintaining his clinical practice, his healthcare experience includes roles in emergency department administration, quality improvement, and resident education. In the colder months, unique health issues often arise due to the weather, the temperature. Are there any specific issues you're thinking about for care as we enter this specific winter season?
Oh yeah, for sure. And thanks, Noah, for having me on the podcast again. Winter is a really tough time of year, I think, in a lot of ways. And we know for sure that the burden of illness really increases in the winter. People get sick more often, hospitalizations go up. People with chronic conditions might have more difficulty controlling those during the winter. And that includes mental health conditions too. A lot of those have the potential to worsen. So thinking about winter wellness in general, there's a lot that really goes into that. But really, there's a few things that come to mind. And probably first of those is just the respiratory illnesses that people sometimes sort of inevitably get during the winter. In the colder months, people spend a lot more time indoors. They're together a lot more often. It's easier for respiratory illnesses to spread more easily. And there probably is some truth also to, quote unquote, catching cold, where the cold weather really sort of impairs our body's immune responses to fight off infection. So all of those kind of combine to make the winter sort of miserable from a respiratory standpoint. And there's a big spectrum of respiratory illness in the winter. Certainly, probably the least severe would be like the common cold, sort of an upper respiratory tract infection, runny nose, sore throat, coughing, those kinds of things. Bronchitis, where it starts to go a little bit more down into the lungs. All of those are usually not too severe. Typically, they're caused by viruses, and they'll just resolve with time and supportive treatment, over-the-counter cough medicines, fever medicines, decongestants, honey, those kinds of things. But it's still important to think about because people with chronic conditions like lung conditions, emphysema, asthma, older adults, these simple viruses can pose risks to those people and cause exacerbations in their chronic conditions. And so it's important to be kind of aware of that. Unfortunately, these infections are, even though they're not severe, there's not really directed treatments. Antibiotics don't work. And so it's just kind of tincture of time for those. But that's far and away kind of the most common sort of respiratory illness that we see during the winter. But there are others to think about that are more significant, one being pneumonia. And pneumonia is basically an infection of the lower respiratory tract, the lungs, where the oxygen goes from the air that we breathe into the bloodstream. And that definitely is an increased risk in the winter as well. Older adults are at higher risk for getting pneumonia, and pneumonia can be caused by viruses. It can be caused by bacteria, but typically when we think about pneumonia, we think about bacterial infections, and so pneumonia is treatable with antibiotics. Signs of pneumonia can be difficult to distinguish from other respiratory illnesses, but typically we're thinking things like, a productive cough, fever, chest pain, particularly with breathing or cough, shortness of breath as well. And people can get very, very sick from pneumonia. Pneumonia is a leading cause of death as well. So if people feel like they're getting really sick and have those symptoms, then they should see a medical professional and determine if they might have pneumonia and might need treatment. And then really just to think about particular viruses sort of swinging back to that direction, there's a couple that really deserve special mention every winter. Those are influenza, of course, COVID, and a newer one that we're thinking about more often, which is RSV. And I would rather take a moment just to talk about each one individually. So we're all really familiar, of course, with COVID from the pandemic. And thankfully, COVID is much less likely to cause severe illness now than it was a couple of years ago. And there's a number of reasons for that. Of course, most people have either had COVID or been vaccinated. So there's a lot more immunity in the population. Also, COVID has mutated a lot such that it's not as virulent and causes less severe disease than it did when it was, first detected. Although it's certainly more infectious now than it was too. So it's kind of, two sides of a coin. But COVID is still possible cause of some serious health problems as well, pneumonia, sepsis, those kinds of things. Most of that burden too is also borne by older adults. So it's still something that's really important to think about and to protect against, even if it's not quite as dangerous as perhaps it used to be. Then influenza. So that seems to come up every winter as well. And sometimes I feel like, as a practicing physician, people sort of minimize influenza a little bit, but it's as like a bad cold, quote unquote, but it's actually a really significant illness. It certainly can make people feel absolutely miserable, but it can actually be pretty dangerous, particularly to older adults. We know that influenza predisposes people to getting more severe sort of secondary infections like bacterial pneumonia and bloodstream infections and those kinds of things. And interestingly, influenza is also associated with an increase in heart attacks. It's kind of interesting, in my practice, I definitely see that at least once a winter where someone's gotten influenza and then while they're sick or a couple weeks later, they'll come in with a heart attack. It's really quite something. So influenza is definitely not something to minimize. It's definitely something that is a risk to, especially to older adults. And then I also mentioned RSV, which stands for respiratory syncytial virus. It's something that we usually think about in the context of babies and small children because they're the ones that usually get really sick from it and hospitalized from it. But there is a growing recognition that RSV can also cause severe respiratory disease in older adults too. So that's something that is more coming to the forefront recently. And so I mention all three of these things because they are probably the most significant viruses that circulate every winter and are most likely to cause bad problems, but also because all of them have vaccinations available. And vaccines are so important because they are far and away the best way to protect against these illnesses. And people are sometimes concerned about the side effects of vaccines and the adverse effects. People can react to vaccines and stuff like that. And while that is true, the risk of the vaccine in every case is far, far outweighed by the benefit. And the risks of vaccines are much lower than the risks of actually getting sick from these viruses. Certainly, people can still have concerns about them. And if so, that's fine. Always appropriate to talk to your doctor about them. But I can't recommend, in general, highly enough that vaccines are considered for these illnesses. And really, just to review the vaccines. So COVID, actually, the current recommendation is for older adults to get vaccinated against COVID every 6 months because we know that immunity really wanes from the vaccine over time. And vaccines, of course, prevent severe illness very, very well. And they don't completely protect against infection, but they also can protect against infection too. Influenza is an annual shot. For older adults, age 65 and older, there's actually a high dose vaccine that's more protective. And that's because obviously influenza is dangerous to older adults. And so we need a higher immune response to create a higher protection. Of course, that higher dose vaccine can come with a higher likelihood of a reaction. And while you actually cannot get the flu from the flu shot, people often will get like aches and fatigue and low grade fevers and that kind of stuff. And so if that's a concern, the standard flu shot is also available even for older adults. And then lastly, there's also an RSV vaccination, which is currently recommended for anybody over age 75. But people who are aged 60 and older can also get vaccinated if they have risk factors like diabetes or lung conditions, or if they live in, a communal setting like a nursing home where they're more likely to get infected. And then the other thing about these three viruses also is that all of them have treatments that are available. And unfortunately, the treatments are not nearly as effective as prevention. And so, the treatments are generally more effective when given earlier in the disease course, but none of them are as good as not getting the disease in the first place, or at least having built-in protection from those diseases. So, but in any of these cases, if someone is infected with one of these viruses, certainly speaking with your doctor about treatment, because not everybody's a candidate, but it is something that's available.
Thank you so much for going in depth on a variety of different respiratory illnesses that can affect folks during these winter months. Are there any other things that people should watch out for, whether that be physical or mental?
Yeah, absolutely. So, we always think about respiratory illnesses, but winter has a lot of environmental issues that can certainly predispose people to other adverse health effects too. So, obviously, winter is the cold season, and older adults, unfortunately, are more susceptible to getting complications from low body temperature or hypothermia. There's a number of reasons for that. Older adults have sort of a decreased physiologic ability to raise their body temperature. They often have more chronic disease burdens, and chronic diseases do get worse in the cold winter months. And then also, older adults are more likely to take medications that might impair their ability to handle hypothermia. A good example of that is like beta blockers that people might take for heart conditions or high blood pressure. When people's body temperature drops, they can get mild symptoms like shivering, but it can also be more significant. Like people can get confused. When it gets cold, all the blood flow sort of shunts to the center of the body and goes to the kidneys. And so people actually can urinate more and get dehydrated in the cold, believe it or not. People can feel kind of weak as well. And then, of course, there's certainly the environmental concerns like frostbite if people are exposed to more direct cold for longer periods of time. And so ways to address that would be, if people live alone, checking on family and friends to make sure that their heating systems are functioning, make sure they have carbon monoxide detectors. Thermostats really shouldn't go below like 68 degrees. It can really be easy to develop hypothermia lower than that. It's important to dress warmly, of course. If people live in conditions that are not as well insulated, if there's like a draft under doors and stuff, putting towels under the doors can help kind of prevent that. Closing blinds, especially at night, can help prevent heat loss from windows and that kind of thing. So it's something to keep in mind for sure. And then outdoors, of course, we see a lot of ice and snow in the winter, and those greatly increase the risk of falling, slipping, significant injury like hip fractures, which we know are the burden of that is borne by older adults primarily. And so prevention, as with most things, is key. So if you know a storm's coming, if there's going to be precipitation, sort of pre-treating sidewalks and driveways with salts to prevent ice from forming in the first place. If it does snow or if ice forms, of course, non-skid footwear, the type of shoes with like rubber soles, low heels, those kinds of things really help prevent falls. Making sure that if there's an assisted device that you're prescribed, like a cane or a walker, certainly the winter is not the time to abandon those. It's interesting, there's probably not a lot of good evidence suggesting that canes or walkers help people who don't normally need them during the winter, but certainly if you are supposed to use a walker, now would be the time to do so and not to skip that for sure, because we don't want to add any other risks to falls that would already be caused by the outdoor weather. And then, of course, with snow comes snow shoveling. And I feel like sometimes people don't appreciate how strenuous of an activity that really is, even for people who are in really good physical shape. During the winter, people who maybe are not active during the rest of the year are now having to shovel snow, and that can really place a lot of stress on their body, not only leading to mechanical injury, but really stressing the heart out quite a bit. And I don't live in a place where it snows frequently anymore, but I did used to practice in a part of the country where it snowed every winter. And inevitably, there were multiple people I saw with heart attacks as a direct result of snow shoveling. And so it's really something to keep in mind. And if there's any question as to whether or not you are able to do that strenuous activity, it's probably best to talk with your doctor first before engaging in that. And if you're not sure or not in well enough condition to do that, to make some other alternative arrangement to get rid of snow. And then you also mentioned mental health, which I think is really important too. The big thing that we always talk about during the winter is seasonal affective disorder, or SAD. And what that really is basically major depression. Typically, it's major depression. It can be other mental health disorders as well, but we typically think about it as depression that's clearly associated with a change in the season. So people might have good mood, overall in the summer and spring, but as fall turns into winter, with the colder weather and less light during the day, people will develop signs and symptoms of major depression, which includes, of course, a depressed mood, fatigue, loss of interest in activities. In severe cases, it can be feelings of worthlessness, even suicidal ideation in the most severe cases. And I should also mention, in the context of suicidal ideation, that there is a National Suicide and Crisis Hotline, 988, that is available 24/7 that people should know about if they are in crisis. And that's really helpful because it's staffed, as I mentioned, 24/7. There's texting options, there's options for people who are hard of hearing. And so that's really important for people to keep in mind for those who suffer mental health crises, particularly in the winter. But getting back to sort of the diagnosis overall in general, what's interesting about seasonal affective disorder is that in addition to sort of typical depressive symptoms, it tends to be associated with almost like a hibernation type of syndrome where people sleep more often, they might gain more weight, eat more, as opposed to depression that might manifest in other parts of the year where people might stop eating or they might not be able to sleep. And seasonal affective disorder is important because, like major depression, it really puts a lot of burden on people's ability to function at work and socially and those kinds of things. But it's also true that a lot of people experience milder forms where it may not be as bad as a major depressive episode, but people still get like the winter blues and those kinds of things. And, fortunately, SAD is treatable, just like major depression. Talk therapy can help, antidepressants, those kinds of things. And people also think about light therapy too. That can come in a lot of different forms, but the most common is like a light box that people can use, especially in the morning for half an hour. It just sort of uh, maybe increases the amount of serotonin that people have, which is the neurotransmitter that affects mood and those kinds of things. And I don't think we really know exactly how it works, but certainly it makes sense that light therapy might help counteract the shorter days. Sometimes people use alarm clocks as well that have a light that gradually brightens, almost like a sunrise effect that really helps some people. And then also, we shouldn't forget about natural sunlight. We're often loath to go outside when it's really cold, but certainly making an effort to go outside in the middle of the day when it's warmest and there's more direct sunlight can also be helpful for folks who might suffer from seasonal affective disorder. So those are kind of the main things that I think about when it comes to staying well during the winter.
Beyond personal wellness, hospitalizations also tend to go up in the winter, and the season can present additional challenges when it comes time for people to leave a hospital or skilled nursing facility. So, I'd like to take some time to discuss discharge planning, a key element of this process, and one that people sometimes don't think about as part of their stay in one of these facilities. So, could you just, for the folks listening, just briefly describe and tell me what discharge planning is?
Yeah, discharge planning is an important issue year round, but you're absolutely right that we think about it, especially this time of year when transitions of care can be really complicated. So, what discharge planning is it's a process for patients who are at one level of care who are transitioning to another level of care to continue their treatment plan. It's really making sure that that transition is as seamless as possible and that things don't fall through the cracks. And it really can apply to any sort of transition of care, even switching from one doctor to another, for instance. But when we really think about discharge planning in particular, generally we're imagining a situation where someone's in a hospital or a facility and they're transitioning to a lower level of care like home. So somebody who's discharging from a hospital to a skilled nursing facility, or someone who's in a nursing home who's transitioning to home, for instance. And so there's a lot of moving pieces in that process. And it's very complicated. And it's something that's extremely important to make sure that the transition of care is appropriate and that things, like I mentioned, don't fall through the cracks and that the treatment plan continues seamlessly. That's really what we mean about discharge planning.
Dr. Stoffram, could you tell us the current standards of care for discharge planning?
Yeah, absolutely. Because it's such a critical process to healthcare in general, there actually are sort of standards of care and expectations that are laid out actually in federal law and by Medicare. So I'll go through some of those aspects. So really, discharge planning, even though it's about the transition from, and I'll just use hospitals as an example, from being hospitalized to going home, let's say, even though it really seems to be associated with that last piece of leaving the hospital, it really is a process that should start as soon as possible after admission and be very proactive and be regularly updated. And that's really just because as the date of discharge approaches, there's so much to have in place that having a proactive plan really avoids those last minute changes, uncertainties, delays, those kinds of things. And so really the first standard is that it's a proactive process that starts at the time of admission. And that goes for things like skilled nursing facilities as well. But legally and from a standard of care standpoint, it's actually a requirement to provide discharge planning. It's a necessary component of care, just like medications and nursing and therapy and those kinds of things. Discharge planning has to be provided upon request of a patient, the patient's representative, or the attending physician. Although I will say that because of the importance of discharge planning and the recognition of that importance, it really is basically standard now for anybody who's admitted in a hospital or a skilled nursing facility to have discharge planning. So you probably don't need to request it, but it is something that must be provided upon request. Other things that we think about are that discharge planning is very patient-centered, just like any medical care. And what that means is that the patient's goals and treatment preferences have to be taken into account. And that doesn't mean that the patient gets to necessarily dictate what happens. Certainly, the medical provider has to make their own recommendations about what they feel is best for the patient. But if there's multiple alternatives about where someone might be able to go after a hospital stay, then really the preferences need to be taken into account as much as is medically reasonable. Ideally, and if there's a caregiver or a support person that the patient uses, a spouse, family members, someone who might be providing care when they leave the hospital, the discharge plan should include their input as well. Discharge planning, because it's really complicated, is actually really considered kind of a skilled service that needs to be provided by somebody who's qualified. Typically, that might be a social worker. It also might be a case manager. Typically, a case manager is a registered nurse, although it could also be somebody else. But I'm seeing more and more in my own experience that discharge planning is often provided by a team that might include both case managers and social workers, but it has to be provided by somebody who's qualified and knows the services that are available. If someone needs further services, like for instance, if they're going home with a home health agency that's going to continue to provide care a couple times a week, then it's really important that the facility provides assistance to the patient in arranging that. And importantly, that the patient gets a choice of multiple providers. The hospital has to help someone select from a variety of different options and not necessarily push them in one direction or another. So that's another patient-centered component of discharge planning that's really important, where the patient gets to select their own provider. And then once that selection is made, the facility has an obligation to kind of get things started. So to do the initial part of the plan. So for instance, if a patient selects a home health agency, the hospital would then have to make the referral to that agency. If a patient is going to a skilled nursing facility after they leave the hospital, then the hospital has to arrange for transportation. So they have to kind of get things started to the extent that they're able to. And then the last thing I would say that goes into discharge planning is for Medicare beneficiaries. If they are being discharged from the hospital or they're transitioning away from skilled nursing facility services, those facilities also have an obligation to let beneficiaries know that they have the right to appeal that decision in most cases. And so they usually provide that verbally and in writing. But that's also an important part of discharge planning.
So let's say I'm in some sort of facility, or I'm with a loved one or a family member, and I've got those discharge papers. Is there anything in particular that I should look out for as I'm going through this plan?
Yes, absolutely. And it's going to vary based on what a patient needs. You know, some people who are in the hospital for a simple problem and they're sort of back to their baseline may not need much in the way of discharge planning, but that's usually not the typical case. Most people do need some ongoing care and instructions. And so there are a couple of things that people should expect to see when they get a discharge plan. The first thing is that there should be information in writing that sort of summarizes the episode of care that they've just finished. Usually that would mean, like, for instance, why someone was admitted to the hospital, what their main diagnosis was. The plan should also include educational materials about that diagnosis, instructions for further care. And that can vary based on what the diagnosis was, but an example of that might be training. So, for instance, if somebody is admitted to the hospital and they were just diagnosed with diabetes and they need insulin, so obviously part of the discharge plan would be that the nurse should teach that person or their caregiver how to administer insulin, how to dial it up on the pen, how to check blood sugars, and how often to check blood sugars with the meter. That has to happen before the patient leaves the hospital. Another example might be certain dietary restrictions. So, for instance, if somebody has an admission for high blood pressure or congestive heart failure, they're often instructed to avoid high salt diets or to weigh themselves on a daily basis and to report significant fluctuations in weight to their doctor. And that's another thing, also reasons to call your doctor or reasons to return to the hospital, so called return precautions. Those really should all be specified and written out. And so if there's any questions that aren't answered in the written summary that are of that ilk, then it's really important to mention that and ask about that prior to leaving the hospital or the facility. Another critical component of discharge planning is a medication list. And there's a process that is a standard of care called medication reconciliation or MedRec. And what that really is reconciling the different lists of medications that might be associated with an episode of care. So, for instance, if somebody's hospitalized, they obviously have a list of medications that they took at home before they were hospitalized. And while they're in the hospital, there's a different list of medications they were taking in the hospital. And at the time of discharge, what the physician needs to do is to reconcile those different lists and basically hand the patient a new, corrected, updated list of what they should take at the next level of care, whether that be a nursing facility or at home. So, examples would be maybe the patient was hospitalized with pneumonia, maybe they're going home on an antibiotic that they weren't taking before, or maybe they were hospitalized with a stroke and they're leaving the hospital with a blood thinner. Or maybe they were taking a medication before and that medication caused a side effect that contributed to their hospitalization, and now they need to stop taking that medicine. So, when a patient is discharged, the discharge plan should include a very clear list of all the medications that they should continue to use going forward. And that list should replace any list that they were previously using. So, that's super important and is an essential part of the discharge plan. Another thing is if someone needs ongoing care or equipment at home, then of course the hospital needs to arrange that. They really should be sort of assessing what needs someone is going to need when they're at home. And again, like I mentioned earlier, providing a referral for things like home health and those kinds of things. But it's important to know that home health, usually that doesn't mean that someone's going to get a daily service. So if someone needs a physical therapist at home or a nurse to come out and change dressings or, provide further education about medications, usually that's not happening every day. So there needs to be some sort of assessment about what someone's going to need on a daily basis. For instance, if they're leaving the hospital in a little bit of a weaker state than maybe they entered it, they may need to move in with somebody for a little while. Maybe they need to hire a caregiver. Maybe if they live in a two-story house, maybe they need to kind of set up a living situation on the ground floor temporarily. The hospital really should help someone kind of make those decisions. Similarly, if someone needs equipment like a bedside commode or a CPAP machine or something like that, or they now need a walker and they didn't before, then the hospital should include that as part of the discharge plan too. And then lastly, certain things like community services that might help fill in some of the gaps, like Meals on Wheels. The hospital should be helping provide information about those, sometimes even making those referrals and setting those up on their themselves as part of the discharge plan. And then the last thing I would mention is follow-up appointments. So obviously, care is a continuum. A care plan never stops at one transition of care; it always continues. And so, part of continuing care is getting follow-up appointments with physicians, primary care doctors, specialists, those kinds of things. The discharge plan really should specify who someone is supposed to follow up with, roughly when they're supposed to follow up with them as well. And a lot of hospitals will actually make appointments for you, but not all will. And so it's really important that the discharge plan is very clear about who to follow up with, when to follow up with them, and if you have to make the appointment or if the appointment's already made for you. So those are kind of some of the essential things that really should be in any discharge plan.
So I've gone through this discharge plan with my loved one. We're preparing for, let's say in this scenario, they're returning home. What can somebody do to make sure their home is ready for their loved one or family member to return from their stint in the hospital or facility?
Yeah, that's super important. I kind of alluded to it earlier, but you're absolutely right that that is a consideration that really should be taken into account. And the hospital can help with that, but a lot of that responsibility can fall on the patient or their caregivers or family members. We sometimes think, if somebody's admitted to the hospital, they're sort of at their baseline health, and then they get admitted to the hospital, and then they get treated, and then they're back to their baseline when they go home. And honestly, that's really almost never the case. Typically, people have some fatigue or weakness. They're not quite back to their baseline when they leave the hospital. And so it really can be a precarious time, especially for older adults. And they can fall and they can have safety hazards. And so thinking about the home environment and optimizing it for safety are really critical components of that transition of care. So, like I mentioned, facilities really should ask about the home environment if the plan is for the patient to return home, and that can include, who they live with, who's available to provide care. Also, the physical layout is really important, and really they need to help establish kind of what accommodations might need to be made. For instance, if someone has a really tight bathroom at home and now they have to use a walker to get around, that may not be something that they can continue to do in terms of using that bathroom. So maybe they need to set up a bedside commode and provide that and have that delivered to the house and those kinds of things. Like I mentioned, a lot of people live in multi-story houses. So if you're used to living on the second floor and your bedroom and bathroom are there needs to be some way to make sure that an accommodation can be made. Perhaps if somebody's unable to climb stairs because they're weak and they might be getting physical therapy, but they're not quite back to their baseline yet and can't safely negotiate the stairs. We need to think about ways of making a temporary living setup on the first floor if they're going to go home and those kinds of things. So screening the house for hazards really is what's most important. And that can also be things that we may not even recognize because we're so used to living in our space. If there's an extension cord or a rug or a carpet that's loose that someone can trip over or a floorboard that's a little bit loose, these are things that we might not appreciate because we live in that situation. But having someone come out and actually do sort of a home safety evaluation can be really helpful. And that is something that can be arranged as part of a discharge plan too. So someone like an occupational therapist as part of home health services can come and on their initial visit, they can do something like a home safety evaluation to help people detect hazards that they may not have appreciated. So they would look for things like that. They'd also look for like smoke detectors and carbon monoxide detectors and fire extinguishers and escape routes and those kinds of things that we may not think about. And then they can also look for opportunities. So, for instance, like the bathroom example, if there's an opportunity to maybe add a grab bar for a shower or a handrail or something like that, those are things that can also be done through a more formal home safety evaluation. So, it's kind of all hands on deck. Everyone can kind of contribute to making sure that someone's home is ready for return, but definitely something important to think about as part of the discharge planning process.
Earlier, you mentioned that as a part of the discharge process, a patient's going to be aware of their right to appeal. Of course, one of the things that we do all the time here at Livanta, could you talk a little bit about how Livanta and the services that we provide can be helpful throughout this discharge process?
Yeah, absolutely. And you mentioned the appeal process, which is one of the main things that we do as a BFCC-QIO. And I would say that with that process, discharge planning figures into it immensely. It's one of the very most common reasons that people reach out to us. And that's really because discharge planning is an essential part of that decision to discharge someone from the hospital or to terminate sort of skilled nursing facility services. An essential part of that decision is arranging an appropriate discharge plan. And so if people feel that they aren't ready to do the discharge plan that's been laid out for them, then they will often reach out to us. And an appeal is certainly one of the ways that they can do that. And that would apply even without regard to discharge planning. If someone feels that they're really not ready to go to the next level of care, if the discharge plan is unsafe, if they feel that they still need services in an acute care hospital or in a skilled nursing facility, then they can reach out to us and file an appeal. And what we do is we have physician reviewers who look at the medical records, and we're really looking for evidence to support the appropriateness of that decision to discharge someone from the hospital or to terminate their skilled nursing facility services. And an essential part of that determination, as I mentioned, is finding evidence in the medical record of an appropriate discharge plan, or at least the beginnings of one. And so if the records don't support that that discharge plan is in place or that the decision decision to terminate SNF services or to discharge someone from the hospital is the right decision, then we can grant that appeal and ask them to continue to provide those services until they are able to support that decision in the medical record. And it's a really important protective thing that we do for Medicare beneficiaries, because at the first level of appeal, the patient is protected from discharge from the hospital or from having their skilled nursing facility services terminated while the appeal result is pending. So it's a really important safeguard that we have in place if people have concerns about discharge planning. But that's not the only thing that we can potentially offer. So in some circumstances, someone might agree that they are ready to go home from the hospital, and they may be even eager to leave the hospital. A lot of people would there's nothing they would love more than to go home and get out of the hospital or the nursing home. But they may have significant remaining questions about their discharge plan. They may be asking for answers and not getting them, or they may feel that they may not be able to implement the plan and follow the doctor's recommendations, or they're concerned that aspects of the plan may not be appropriate. And so they're theoretically in agreement that it's time for them to be discharged from the hospital, but they really have concerns about components of the discharge plan. And so if they reach out to Livanta in those cases, we might also try to resolve that concern through what we call immediate advocacy. And that is where we have trained advocates that will sort of serve as an intermediary. They'll reach out to the facility on the beneficiary's behalf with their permission. And the goal is really to improve communication, to solve problems, and to try to improve the interplay between the beneficiary and the facility that's planning to discharge the patient. And the ideal situation is that we would resolve the concern to the satisfaction of both parties, so that the discharge plan and the discharge order can go off as planned, but that the beneficiary feels more confident that it's the right decision and that the transition of care will be more seamless. Both of these services are heavily used, and we encourage their use, and they're absolutely free to beneficiaries, both in the traditional Medicare program and Medicare Advantage programs. And it's really not necessary for people to know kind of which one would be better when they call. Anybody who has any concern about being discharged from a skilled nursing facility or from a hospital should simply reach out to us, and our intake providers will ask some more details and really determine the best person to get that person to, and we'll basically be able to help you with whatever you need in regard to the discharge planning. We'll take care of it for you. All you have to do is just call us.
Thank you, Dr. Stoffren, for sharing information about Livanta's QIO services that are provided at no cost to Medicare beneficiaries. Before we go and wrap up, is there anything else that you'd like to share with our listeners about discharge planning, about winter wellness, or the services here at Livanta?
In many, many ways, as we kind of reviewed today. And I want people to know that as part of the Medicare program, they are never alone. There's so much assistance just waiting to be used. We really want to provide that help to people. As you mentioned, it's absolutely free for Medicare and Medicare Advantage beneficiaries. And don't hesitate to call us. Even if you're not sure if we can help, we can get you to the people who can. And we're here for you 24/7, 365.
As we wrap up this month's episode of Learn with Livanta, we wanted to remind you that more information about the BFCC-QIO and your state or territory's helpline number can be found by visiting our website at www.livantaqio.cms.gov. That's www.livantaqio.cms.gov.